Oh, I'm so sad not to be there in person because I even during the break I could hear some really interesting conversations, and but hopefully we'll be able to have those in this session together. So I'm hopefully going to do very little talking. I think you've heard lots of detail about the staging system from Katie, from Martin, and the background to why it's so important. What we're trying to do as a group, Helen, Katie, myself, lots of other colleagues from all the other organizations involved, is to figure out, this is a really complex, new, different idea to try and explain to the wider Parkinson's community, most of whom won't be able to come to an amazing event like this and spend a whole day getting to grips with what it means and all the background and detail. So how can we explain this simply and quickly to people in a way that will be meaningful and helpful, hopefully? So we've been giving that some thought together and tying ourselves in knots, probably. So it would be really great to road test some of those initial ideas of how we might explain this to you and to hear feedback. So I'm hoping, like I say, I'll be very quick and give you a very top line idea of some of the messages we've been thinking about. And then, yeah, it'll be over to you to kick the tires, tear it to pieces. That's what we need. We need to hear that feedback. And yeah, I'm really excited to get into that discussion. So I will try and share my screen, and then we can just whip through some slides. And hopefully you can see this.
Yeah.
Perfect. Okay. I think I have to look at the slides, and so I can't see anything. So I'm just going to talk to myself for a minute. Bear with me. So yes, so I'm going to give you a sense of where we're at with some of the messages we've been working on so far, and then that's going to be really quick, and then hear your thoughts and ideas. And I've got a few questions to get the discussion started. So firstly, I think really one of the most important things we need to be able to explain to the wider Parkinson's community is what is the purpose of this staging framework. So here is an attempt at explaining the purpose, and that is to use biological tests to improve the way we select people for clinical trials to assess promising new therapies. And by using the staging framework and these biological tests, we can identify the right people for trials, and then within those trials monitor progression better, giving those trials and those treatments a better chance of succeeding. How will that improve ththings? We also know or believe that disease-modifying therapies, which are the thing, I think one of the main reasons we need this staging framework is we can't measure whether things are actually modifying the course of the disease, are most likely to be effective the earlier they can be given. And we know as well that by the time people are diagnosed, based on clinical symptoms, they may have had Parkinson's for many years. We've heard, like from Gary, for example, that feels like it was the case for him. So if we can use biological tests that can identify people before symptoms appear, it gives us that a real opportunity to start testing treatments in people who may show benefit more easily. And how does this work? So, as you've already heard, the new staging framework is based on two biological tests that we have already and that have previously been used and validated in clinical research. The first is the alpha-synuclein seed amplification assay. I wish it wasn't called that. And that detects the presence of misfolded alpha-synuclein in the cerebrospinal fluid, which is taken via a lumbar puncture currently. The second is a DAT scan, which is probably much more familiar to the Parkinson's community, as this already is in use clinically, especially actually in the UK. So this is a brain scan that can be used to detect the degeneration of dopamine-producing cells in the brain. So what does the staging framework look like? So Katie showed you a couple of examples of sort of more scientific representations of how it works. I have tried to make that simpler. I don't know if I've succeeded. Let's see. So here we are. Stage is across the top. So as discussed earlier, there's this R stage, which is risk, people who are at risk of developing Parkinson's based on having a gene that increases risk of Parkinson's, whether that's by a small amount or a large amount. Stage 0 is that group, very small group of people that Katie talked about, who have a genetic change that pretty much guarantees they will develop Parkinson's, so a change in the alpha-synuclein gene itself. But this is a very small group. And then we move into the proper staging system, I guess, that once people actually start to have the biological markers. So stage 1A, people have a positive synuclein test, positive lumbar puncture test. Stage 1B have both synuclein and DAT scan. Stage 2A, people have synuclein but don't yet have evidence of dopaminergic deficit from a DAT scan. However, they have started to develop some very early symptoms, things that were discussed earlier, things like maybe losing sense of smell, constipation, maybe some sleep problems. Stage 2B is when people have synuclein DAT scan and symptoms, but still no impact, or these symptoms are still very, very mild. And then we progress through 3, 4, 5, and 6, and this is just symptoms becoming more impactful in terms of day-to-day living. So I think it's fair to say that, as Katie discussed, I think, mostly people currently, based on clinical diagnosis, are diagnosed probably from around stage 3 onwards. Some people, maybe rare occasions, will be diagnosed based just on clinical symptoms earlier than that. But for the majority, we've been really looking at this group of people when it comes to clinical trials, and not this group of people. So having these new biological markers opens up the opportunity to actually include this group of people in trials for potentially the first time. So going back again to something that Katie touched on in her talk, who does this staging framework apply to? And I think this is something that we think, well, it would be interesting to hear your thoughts on how important this is. Because this framework is built on 2 current biological markers that we have, the alpha-synuclein marker and the dopamine brain scan. From the research that's already been done, we believe that those people with Parkinson's, people with a diagnosis of Parkinson's, probably about 90% of people would have both of those things, but 10% might not. And therefore they may feel excluded by this framework. And it'd be interesting to hear the thoughts of people in the room about how important that is. We also know that many people with dementia with Lewy bodies also have misfolded alpha-synuclein and dopamine dysfunction, although it's less clear what percentage, because there's been less research. So I think another thing that's interesting about the framework is it isn't just about Parkinson's, it's also about people with things like dementia with Lewy bodies who would fall into this framework and potentially be involved in clinical trials that address both conditions. So that's something that's a little bit different. And just to note there that people who do not have misfolded alpha-synuclein and dopamine dysfunction, yes, they may not be eligible for some of the trials that might use this framework in future, but that would be because they're unlikely to benefit potentially from those therapies. And I think that came up in Katie's talk too. And then just on the future. So as Katie said, this staging framework is a start. It's a starting point. It's the beginning of a journey. It's not perfect, and there is loads of room for development and improvement. So things like, we know lumbar punctures don't sound like a lot of fun. I've not had one, but that would not be the ideal way to do an alpha-synuclein test. And there's lots of work going on to try and develop better ways to do that test that are less invasive. Perhaps just a blood test would be much more accessible for people. And also we know we want to add, have tests that aren't just a binary. So do you have misfolded alpha-synuclein or don't you have it? Instead, it would be great if we had a test that could tell us how much there is, or like gradation within that, that could give us that idea of severity moving forward. And I think we're wanting to present this framework as something that we want to build on together with the research community, with patients like yourselves, with companies and regulators, to improve it, change it, adapt it, add to it, so that we can make it work for trials as best as it possibly can, and together to move that forward at pace so that we can actually start using it in clinical trials. So I think that is everything I was going to say. Those feel like the most important messages, from our perspective for the patient community. But now we really want to hear from you and what you think the most important things are for us to say about this staging framework. And so here are some initial questions to get us started. So what do you think? What is your take-home message from everything that you've heard today? What is the most important message that you would go and tell someone else that hadn't been here? What aspects of this are confusing, need better explanation? What are we confusing you with? Because it is pretty complicated, and it's taking me quite a while to get my head around it. What do you like about the idea that's been presented today and the idea of staging? What feels good about it? And are there any things that don't feel so good about it? Anything that you're worried about or think, I don't know how that's going to work? What questions do you have? And how do you think we should communicate this? Like, what mechanisms should we use to reach the wider patient community and let people know about the work that's being done? And anything else you think of, we would love to hear it. And I think I'll stop there and hope that I can come back to the room and actually hear some other voices.
Thank you very much indeed. Okay, so I think we've got a couple of options here. We can either break into smaller groups to discuss these questions that we'll put back up on the screen and just move the chairs around in here, which I think would be a really good idea, because I think we'll be able to tease through some of the questions a little bit more. Or we can discuss them collectively. But I think what we might do is first of all just start off with these questions. And if Sean, you're okay to start with a group here. Yeah. Matt, would you help me with Martin to join a group at the back here? And then if Rosie, you and I set up a group around here. And so go to those three areas and just let's move some chairs around and discuss in that way, if that's all right. You need to go. Thank you very, very much, because actually breaking into groups I think was incredibly helpful, because I think being able to talk about this in a smaller group setting rather than all together perhaps allowed everybody to just really share their thoughts. It'd be really helpful to hear back from each of the three groups. Sean, would you be in a position to go first, or would you like Matt to go first?
Yeah, I can go first.
You sure?
Yep.
Fantastic. Am I allowed your notes afterwards? Just so I don't have to scribble vigorously now?
Yeah, you probably can't read my writing.
So
all right, so one of the questions that I had was, how is impact determined? So is that simply quality of life, or is that a patient walking down the hall to see the impact of the disease? And then we talked for quite a little bit of time on the different staging and staging system. And some felt that the word staging was a little negative and perhaps suggested stratification. The group really felt that it might be better to keep it more simple. For example, many of the patients who have Parkinson's disease don't really care. Sorry, that's not the right word. They don't relate to a patient who has the gene for synuclein and who then is automatically going to be getting the disease. And so because of that, they didn't really understand the 0. And then the R was for patients with genetic risk. And that really doesn't apply to the majority of patients either. So perhaps making it simple, having less detail would be helpful. And the term biological might have some negative connotations here in the US. So maybe just use it as a medical test rather than using the word biological. Yeah, that's probably about it.
Wonderful. That's really helpful. Thank you. Katie.
Can I ask for an interesting comment around staging could read negative, suggest stratification? Could you elaborate on that?
Someone said something about staging of a house.
Oh,
And that's where the negative connotation came in. Can you elaborate?
I wouldn't say it was a negative connotation as much as it was just, it seemed like an awkward verb, implying that the patient is somehow being staged. So we didn't have really a problem with each stage having a number, but talking about the staging just didn't seem like the right verb for the occasion.
You're being classified and even almost like somebody has a chance to move themselves. It's not a word we use that often for people.
Really interesting. Katie, Claire, any other comments?
Don't think so. Why has biological got negative connotations?
I said that just because a biological test to me sounds foreign. I don't know. Not foreign as in country foreign, just, I mean.
Sounds barbaric.
I just, why just, it's a medical test. It's just a test.
Yeah.
I think it's, to me, there were more internal medical terms on there than what, as a patient, we don't need to know specifics sometimes.
Thank you.
Maybe one, just to comment in response to, I think, the first bullet, which was a question on how do you determine functional impact? And that's a work in progress, and one that there's a lot of interest around from different types of researchers in academia and industry, people with expertise. Like, you could go to school to learn how to develop measures, which sounds very boring, but important nonetheless. So it's vague at the moment because it hasn't been decided. So it's very helpful to hear that you've already picked up on that, and how we contextualize what comes next is really important.
Fantastic. Matt, would you like to feedback from your group?
Sure, where are the microphones? Can you hear me here?
I can, but why don't you come up here?
Maybe, I'll have to. So, the group at the back.
That chatted for really a lot longer than was necessarily required of you.
We had so much to say. So, in terms of the most important messages, there was a feeling that we were moving from a defensive approach to an offensive approach in how we approach doing clinical research. There was, in terms of what needs to be better explained, there was also a comment around getting into clinical trials at the moment is hard. Is this going to make it easier? Another point of what's the difference between the Holland-Yar scale and staging, or how do they intersect with each other? What does it mean? Need more explanation on the difference between, this is reference to your table, Claire, the x-axis and the y-axis. So the biological measures compared to staging 1, 2, 3, what do they mean for diagnosis versus research progression versus how you might be doing measurement? One of the things we liked was the idea that this might shorten diagnosis. There's a hope that this will shorten diagnosis. Concerns, we have a few. There's a feeling that there's still a lot of work that needs to be done. There's concerns if we move towards calling this a synucleinopathy instead of Parkinson's disease, because Parkinson's disease is, the term Parkinson's has taken many decades to get some level of penetration in society. Still largely misunderstood what it is, but at least many people have heard of it and know someone who has it, or a famous person who has it, and don't want to go back on that. But also, Parkinson's is a lot easier to say than synucleinopathy. And to write. And yeah, simple but very useful point. There's a general feeling that staging is good for research. However, people don't want to find out or don't want to know if they're a stage 2 synucleinopathy patient or a stage 1, or that they've moved from stage 2A to stage 2B. The researchers can have that and record that, but not something that they necessarily want to see in, I guess, their own health record or their own notes. Concerns about how one pushes this from research into the healthcare system, because also recognizing that people currently have a very long window to diagnosis right now, and you've also shown that there's the stages currently 0 through 2 are rarely in clinical trials. And part of that is people aren't getting identified by the healthcare system, aren't getting diagnosed. And whilst we're already at a point where general neurologists are struggling to identify Parkinson's within 1 year, 2 year, 3 year, and sometimes specialists as well, how do you, because on Katie's slide was very clear, right now today, this is not for healthcare, right? But there was a concern that it needs to be, because otherwise people won't get diagnosed under these terms. And so how do you connect the two ideas together? Exactly, so there aren't enough neurologists. How do you bring staging to the general neurologist or the general physician? Especially given that we're talking research, and that typically is with the specialist neurologist, and rarer, but sometimes in the US also with the general neurologist. That's it. You are very welcome to my hieroglyphic.
So he's scribbling like
Did I
that.
miss anything from the group at the back?
You did a great job. Katie, do you have any questions for Matt?
Maybe, Matt, would you be willing to run a poll and report back? So we've talked about, I liked the point that Parkinson's has awareness, so do these other conditions in the Venn diagram from hell. And I think it's part of an identity. I mean, there's a community of people. And so I'd be curious if you had to do my children's voting of thumbs up or thumbs down, reactions to a concept of adding a term versus substituting a term. So for example, my Parkinson's is caused by NSD, or my REM behavior disorder is caused by NSD, versus saying that I have a different disease. Do you want to do a poll for me?
I can do a quick poll. So, as far as I understand it, would you prefer to replace the term? Who would be in favor of replacing the term Parkinson's disease with synucleinopathy disease? Thumbs up, thumbs down. It's pretty much a total thumbs down.
Yes.
Would you accept adding to Parkinson's disease with a synucleinopathy? So like I am I am Parkinson's disease with positive synucleinopathy in the records. That's a general down, but some yeses. I guess the third one will be, I'm a S2 Parkinson's disease patient, or an S3.
So you're saying you're gonna specify different types of Parkinson's. How do we want
Potentially
that?
based on the biological
What stage you're in.
classification.
Yeah, your biological
So you could
stage.
either do it based on the staging, the x-axis, or you could do it based on I'm someone with Parkinson's disease who's ticked the boxes of dopamine scan, of seeding assay, of genetic background, of age, of smell test.
I guess I don't understand the context when we're telling our friend work about it.
Yeah.
Or
No,
what are
this
we
is
talking
mental.
about? What the medical doctor puts down on his diagnosis thing, he can put whatever is useful to him. What do I care?
I think it would make a
Okay.
difference if the treatment were different.
Right, but
Like if you said, I have this because of this, then your medicine is different.
So it's like
But if you're just doing the same old,
until there is a
Yeah.
medicine that differentiates based on some of those criteria,
it doesn't
it doesn't matter. As
Exactly.
soon as there would be a medicine that differentiates based on those criteria, then it would be more interesting.
yes.
Well, it kind of,
We
what's
gain
interesting
something,
though is
call it
that
anything you want.
by defining the stage number, you're kind of defining where you're at in the progression of the disease. You know,
Yeah.
and there's some people want to know,
And many don't, as far as I know from speaking to people. Did that help you, Katie?
So then you
Yeah.
want.
That's very helpful, and I think the point about it,
Oh,
some of these shifts will happen and move into medical practice versus just research when their treatments are different. And I think a good parallel of what I heard, and I think the way that nonprofit partners are thinking about this is in the cancer space. I have HER2 positive breast cancer because that means I might have a different treatment, but I still have breast cancer. I don't not have breast cancer because it's caused by a different biology.
Yeah.
Right.
This is
Good.
great. Claire,
Great.
did you have questions?
Not questions, but I think just a reflection is that even if we are saying in the messaging, this is not going to change clinical practice, this is not clinical practice right now, that is where we should be talking about it anyway, because that is where ultimately we want it to get to. Because we want this staging framework to lead to treatments that mean that these tests are done in clinical practice.
You're saying it's more about how you set your priorities of where you invest your efforts on communicating it, rather than saying it isn't for.
Yeah, I mean, ultimately that is the goal.
Yeah. Okay.
So maybe we need to stop being so coy.
Helen's turn.
Well, so actually, I probably need a bit of Rosie's help on this one to chip in, and also definitely Dan and anybody else, Dan and everybody else who was in my group, because my notes, I think, were rather paltry. However, one of the things that we really talked about a lot was around how do we move from the lumbar puncture to the blood test, and whether that could be a broader call to action for people to get involved to support their loved ones to develop the test, and how we do that. Because that would suddenly make everything feel a little bit more accessible. So I'd love Katie and Claire's comments on that as a first start.
So, oh boy. Well, there's two things I would say for the Fox Foundation, and I know other funders, this is one of the highest priorities. And I think it requires two things. Well, science to work out, but I'm not talking about that. I think it requires people to participate in observational studies and find ways to engage in research and contribute data and samples, because without that, there's no resources to test what tools that are in development are going to work. And the other is funding support. And I think this is, the call to action to participate in research or to contribute to charities that are funding research would be two important ways to do this. And I think the other piece, Helen, maybe I know you could talk about this ad nauseum, is asking for, when reviewing consents, that they be able to open share data and samples, so that it's not just helping one science experiment, one laboratory, but that the data and samples that you're contributing to research could be shared with a broader research community.
Katie, you've raised my favourite soapbox. I might stand on a chair and start shouting about it, but it is one of the things that does concern me almost the most, is that people will take part in one study and that data will get locked into one study unless you have created and generated, and the study itself has generated broad consent so that your data can move from study to study. And I suppose I come back to Jessie Keaveney, who is a wonderful Parkinson's advocate, who does not have Parkinson's, but she has a strong family history of LRRK2 Parkinson's. And she's taken part in something like 23 studies and has had, I don't know how many lumbar punctures, and I don't know how many blood draws for genetics. And each time that data has been locked into a little silo. And if she had a data passport so that she could pass her data from study to study and with the codes on it, that would actually be really helpful. So the data piece is massively important. Broad data sharing is something that we've talked about in rallying before, and making sure that people really understand how their data is being used, and that they are asked that it is used in a responsible way, like sharing with the critical path of Parkinson's, that is allowing the broader effort to move forward. Rosie, what else did we talk about in our group?
So I think a lot of it's been covered already, but just to reiterate, one of the things that was mentioned is that currently we know that people don't get involved in research necessarily for their own personal gain. So understanding how that interacts with the state system that kind of looks to stratify people into trials where they would benefit. understanding or communicating why this is happening, what are the benefits of this in order for people with Parkinson's to get behind the efforts, making sure that all the communication is in lay language, as has already been said, and particularly focusing on communication around lumbar punctures, and sort of, again, bringing people on board with that, which is an invasive and scary procedure, and making sure that people know why it's necessary. Understanding who this is relevant for, and making sure that families and care partners are involved in how this is relevant for them and how it impacts them. I think that's it, unless anyone from our group wants to shout.
Clarifying that it was drug trials only.
Yes.
And clarifying that it didn't refer to phase 1 drug trials. Right?
Yeah. Oh,
I didn't catch the last bit.
it doesn't really relate to phase 1
Okay.
clinical trials, purely because that's around safety and quite often involves healthy controls. For healthy individuals. So thinking about this is about trials that are involving people with not quite stage 0 to stage whenever. And I think actually one of the other things that we touched on was being really clear how, when we have new biology that's confirmed, how that gets bolted into this staging system, so that it's clear that we're working on the biology that's being confirmed now, but that it has to grow. And Katie, you made that very clear, but I think that this is something we need to really stress in all communication.
To say, Helen, I mean, I know you just focused on healthy control or healthy volunteer phase 1s, but even in a phase 1b, the objective is still safety. You're not measuring efficacy as a primary measure, and the trial's usually too short to get any benefit as well. So there's just to say, we wouldn't want to broadly communicate that it's only for healthy volunteers and also not for the others. But I think to the point made, phase 1 is a little bit of a different kettle of fish.
Yeah.
And we just need to be careful how we communicate that.
Katie, Claire, any other comments?
Only that this, I think it's just so helpful to hear people's responses on this, and I'm thinking totally differently already about how we might want to communicate the staging framework, but just not this only, but just like the whole journey we want to go on, because I don't think we're communicating that very well yet. So yeah, really, really, really useful. Thank you so much.
Thank you.
And a similar note, and thanks. You're seeing a peek under the hood of the airplane as it's like being built. It's not even close to getting off the ground or to the runway. And I think this insight is really valuable for partners like Cure Parkinson's, Parkinson's UK, Michael J. Fox Foundation, that sit at this intersection of the research and patient family supporter communities, that this is the guidance that we need to be able to tell the story of, you know, why our research priorities are in certain areas, and to tell the researchers this is what needs to be considered as you move forward, and they set their own priorities. So thank you for looking under the hood of a very incomplete and nascent airplane that's going to take us to new places.
Thank you both so much. And just to sort of recap for tomorrow, we've got sessions with Gary's coming, I hope will be coming back and talking about his pipeline paper and talking through that rather wonderful donut that Martin showed earlier on actually how vibrant the drug development space is. And I hope that with that, it'll set the context on how frustrating it could be if those drugs hit the buffers, because we're not defining carefully enough who's going into the trials and then how we're going to measure those trials. So I think it does set the scene quite well for that. I think you then hear from Rosie and me on some GBA trials, so quite a genetic target and what's looking there. We're going to hear from the Roche team about how they've been using wearables to create a longevity around readouts from clinical trials. And I think that that's also helpful because again, it means that we're trying to find ways of making sure that things can fly rather than they don't hit their primary outcome, and that's that. So what we're trying to do is just to make sure that we can learn everything that we can. And then we're also, again, here tomorrow from the very wonderful Sonia Gandhi, who's based in the UK, starting to think about how we put two drugs together to match the biology that is underlying the disease for that individual, so that we could actually hopefully change the disease and move towards a cure faster. But that's very early thinking. So Sonia said, you've given me a right headache on the plane, Helen. But thank you so much for so generously coming to join and share your views with Sonia's session earlier, but also with this session. I think, as Katie said, this is a work in progress and we're learning as we go. And it's really helpful to get this input at this stage before we start doing this broader communication. And it's really helpful to hear from people who don't know about it, rather than people who are quite close to it. So this input is so helpful. Thank you very much indeed. And with that, looking forward to seeing you all tomorrow, and thank you for joining us. Thank you.